was gonna say.
All right.
So I'm pretty sure we're. My watch is green on. That's what it is. That's like.
Everybody see that?
It's like a very.
We see you, Brian.
They're not. So, yeah.
Alrighty.
Right now,
Any questions before we start?
thanks for the.
Oh, yeah. That's what it'll do, yeah.
No, I'm just scared.
You gotta go back. I have something in my hand. All right, no matter how bad things get, your patient deserves better. They're probably at the worst point of their life. Always be the EMT that you want, you were the patient. Whatever happened before should not affect what you do next, unless it's a positive building block. And if you're doing something you care about, you want to do, you should be giving 200% every single moment of doing it. Any questions? All right, we're gonna learn about special patients. Watch this. Ba-boom.
Thank you so much. Now I feel like I can teach again. Glad you guys are looking out for me.
These are the things we're gonna go over today.
Wow, that's kind of cool.
I like this classroom better. Developmental Jesus. Developmental disabilities. Sensory disabilities. Physical disabilities. We're gonna learn about bariatrics. We're gonna go over technology assistance devices. We're gonna teach you guys about hospice and the challenges of low socioeconomic and homelessness. Are you ready to start?
Any air in here?
Huh?
Is there air in here?
Same area that's in the other room. Yeah. It's cooler in the other room?
Yeah, it's like stagnant in here,
I have a heat stroke, right?
right?
A heat stroke.
We're all gonna be stripped out by the end of the night. And nobody wants that. Rebecca's all speak for yourself.
Think of it as you're working in EMS and it's a hot afternoon on the 4th of July with high humidity in Chicago.
Valid.
Just think of that's what we're doing here. You're staged under a tree. That's what we got done. All right, developmental disabilities. There's a whole bunch of different ones. Impossible to go through all of it right now. Autism is one of the more common ones. It seems to be expanding. You're gonna come across, there's all kinds of different levels of autism. One of the key things you guys should know is just because they don't acknowledge you and they don't even acknowledge your existence or appear to even know that you're in the room, they are hearing everything, and acknowledging everything. Oftentimes, if you just ask them to do things like walk to the gurney, they will not even look at you, but go over and walk at the gurney. If you try any sudden moves or try to grab them, you will most likely have a fight on your hands. Autism is poorly understood. No one understands the true etiology of it or the treatments. They're getting better at some things, but they're still very, very poorly understood. Any questions? Down syndrome generally starts during fetal development. They're born that way, and again, there are different levels. There are levels from incapacitated up to functioning and independent living. Any questions? And then, of course, TBI. which also has many, many different levels. From anoxic brain injury, structural damage, water trauma, to all kinds of things. Any questions on autism, Down syndrome, and brain injury? TBI. All right, sight. A lot of times you don't even know someone's blind unless they tell you. It's not something you can figure out. Don't yell at them. They're not deaf. For some reason, EMS loves to talk louder when they find out someone's blind. However, deaf people can't hear, no matter how loud you tell them. If you know ASL, that's probably the best way to communicate with them. But most people don't. Pen and paper or a tablet may be the best way to communicate with them. Be patient. Any questions? Cerebral palsy is not fun. It's a catch-all for a whole bunch, basically it's an umbrella term for lots of different neurological disorders. They have full cognitive and mental capabilities, but they have very poor motor function and spastic motor functions. And again, there's all different types and levels of cerebral palsy. It actually is curable with cord blood now. They make the cord blood. There are sometimes they can cure it, not all the time. But anyway, here's a little bit of a video that we hope you'll really like. Maybe. Having technology issues.
Cerebral palsy is an umbrella term for a group of disorders that affects a person's ability to move. This means that not everyone with cerebral palsy looks the same. There is a meaningful future for every child, adolescent, and adult living with cerebral palsy. For every person, there is a positive way forward through treatment and support provided in partnership with individuals and their families. Cerebral palsy is caused by an injury to the brain that usually happens during pregnancy, but sometimes it may happen shortly after birth. Cerebral palsy affects people in different ways because different parts of the brain can be injured. However, it always has some impact on the person's movements, and this is because the messages coming from the brain to the muscles are affected. Cerebral palsy is the most common physical disability in childhood, with 1 in 500 children born in Australia each year. Cerebral palsy affects people in different ways, and this is largely due to the location of the injury in the brain. Therefore, cerebral palsy is described in a number of ways, including the parts of the body affected and the way in which it affects movement. Where the whole body is affected, that is, both arms and legs and the trunk, this is called quadriplegia. Where both legs are mainly affected, this is called diplegia. People with diplegia often also have difficulties with fine movements of their hands. When one side of the body is affected, for example, the left arm and the left leg, this is called hemiplegia. The next way of describing cerebral palsy is to talk about the way it affects movement and the type of movement difficulties experienced by people with cerebral palsy. Spasticity is probably the most commonly known term. Spasticity is present in about 86% of people with cerebral palsy. It results in muscles that become stiff and tight, which can make it difficult for someone with spasticity to use their muscles easily. It is difficult for someone with spasticity to turn their muscles on and off when they want to. This makes it difficult for them to move their arm or leg to do a task, or to use their mouth and face muscles to eat and talk. Some people have a little bit of spasticity, other people have a lot. The impact of spasticity on movement will therefore vary enormously between individuals. You might also have heard the terms dystonia or athetosis. Dystonia and athetosis describe movements seen in dyskinetic forms of cerebral palsy. Dyskinetic or dyskinesia refers to movements that are involuntary. These involuntary movements can become more noticeable when a person tries to move or when they become excited, agitated, or tired. Dystonia results in unusual twisting postures, repetitive movements, or sometimes both. Dystonia can present in one part of the body, such as an arm or foot, or throughout the whole body. With athetosis, we see slow, continuous, involuntary writhing movements that are present at rest and made worse by attempts to move. Around 6% of people with cerebral palsy have dyskinesia, with dystonia more common than athetosis. One of the less common forms of cerebral palsy is ataxia. Ataxia means without order or incoordination. Ataxic movements are characterised by clumsiness, imprecision, or instability. Movements are not smooth and may appear disorganised or jerky. The incoordination seen with ataxia occurs when a person attempts to perform voluntary movements, such as walking or picking up objects. Ataxia causes an interruption of muscle control in the arms and legs, resulting in a lack of balance and coordination. Sometimes people have a mixed type of cerebral palsy. For example, some people have both spasticity and dystonia.
Any questions? All right. Spina bifida. We went over this a little bit before. We're gonna go over it in a little more detail. Or not. Well, the Pet Cemetery one would be cool, but let's not. do that. Oh, let's watch Zootopia too.
Great.
It's really good.
Spina bifida, or split spine, is a common birth defect of the spine and spinal column. It occurs when the neural tube, the embryonic structure that gives rise to the brain, spinal cord, and surrounding tissues, does not close properly. When this happens, some of the vertebrae fail to form a complete arch around the spinal cord, leaving an opening in the spinal column, typically in the lower back. In mild cases, called spina bifida occulta, only a small gap is formed and there are no other abnormalities. The baby may have a small dimple or birthmark with a tuft of hair on the back, but has no symptoms and does not require treatment. When the opening is large enough, a sac containing spinal fluid may protrude out of the spine. This is known as spina bifida cystica. When the sac contains only the meninges, the membranes surrounding the spinal cord, the condition is known as meningocele. Babies with meningocele typically experience mild symptoms. Myelomeningocele is when the protruding sac contains both the meninges and the spinal cord and is the most severe form of spina bifida. Babies with myelomeningocele are prone to life-threatening infections and may suffer from lower limb paralysis as well as bladder and bowel dysfunction. Myelomeningocele also often associates with accumulation of fluid in the brain, hydrocephalus, and Chiari malformation type 2, where the brainstem and cerebellum drop below their normal position, causing problems with breathing and swallowing. The cause of spina bifida is not well understood, but is likely to involve genetic, nutritional, and environmental components. Folic acid deficiency during pregnancy is a well-established risk factor. Because the defect occurs in the early weeks of gestation, folic acid-rich foods and/or supplements must be started when planning pregnancy to effectively reduce the risk. Having had a child with spina bifida also increases the chance of having another child with the condition. Other risk factors include diabetes, obesity, some medications, and elevated body temperature, either due to a fever or use of a sauna or hot tub during the first month of pregnancy. Spina bifida is typically diagnosed during routine prenatal exams. A protein produced by the fetus called alpha-fetoprotein, AFP, can leak into the amniotic fluid and the mother's blood circulation through the neural tube's opening and can be detected with maternal blood test or amniocentesis. However, ultrasound remains the most accurate method for spina bifida diagnosis, especially during the second trimester scan. Severe cases of spina bifida are usually treated with fetal surgery, which takes place before the 26th week of pregnancy. Prenatal surgery may help reduce disability and the risk of developing hydrocephalus. Myelomeningocele identified at birth requires surgery to close the opening within 72 hours. A shunt may be placed in the baby's brain to control hydrocephalus. Most children with severe form of spina bifida also require orthopedic care, bowel and bladder management, as well as treatment of other complications.
Any questions?
Paralysis. All right, bariatric patients, there's a whole bunch of them. Over 9 million just here in the US. These are people that are 50 to 100 pounds overweight. Morbid obesity is 100 pounds over. We're talking people that are 450 to 700, sometimes up to 900 pounds. And they require specialized equipment and techniques to get them transported and to treat them. What happened to my bariatric ambulance videos? What the hell is this? You guys already watched the video on the product computer device. Don't pay attention to the guy behind the curtain. Ignore the man behind the curtain. Alright. I don't even know who that was.
I think you're wearing the same shirt.
Right now?
Yeah.
No. That's my San Francisco Fire Investigator shirt. This is my Chef the Fire shirt.
Oh, okay.
This is September 11th Memorial shirt. Same color though.
Okay.
This is a pretty good one.
We're gonna call the bariatric patient, plan a split plan.
Bariatric patients about 350 pounds.
We've seen people with rotting skin, infections.
I've taken patients upward of 700 pounds. There is no way to safely transport somebody like that unless you're us.
The bariatrics developed because we started seeing a growth, and no pun intended, in people with a 1,000 pounds in patients. So that's when we decided we're gonna go out and develop special equipment just to handle those patients. We have a special stretcher that handles upwards of 1,600 pounds.
We also have a ramp and a winch that we can hook up to load them right in.
Before this winch system, we were getting like, there was 6 people here to lift this guy up.
Back injuries are very common.
We just got a call for a patient with foot pain, so we're gonna set up a bariatric unit, ramps, winch, and we'll bring a stretcher upstairs, get some vitals on our patient, see if he's all right, and then transport him to the ER.
How you doing?
That's Steve.
How you doing?
What's going on today? I like, you like again?
From here down the swim, yeah.
That's from-
It takes certain skills to do this job, obviously some people skills. You're actually gonna have to have some compassion for your patients, actually have a heart. It's good to help them, you know, they're obviously in need of assistance. I mean, it's tough for them getting around.
I started putting on weight around 20 years old. I was around well over 400 pounds at 20, so it's just my reality.
What's your diet?
My weakness, pizza. That's what I eat. The biggest struggle of living alone is just eating whatever you want, not, you know, having anybody there to tell you you can't have it. I'm what they call a frequent flyer.
Go in. Meet you on the other side, Steve.
Yeah, all set, thank you. I'm trying to accomplish my goal of losing weight and becoming a normal size, like maybe, you know, even 300 pounds would be good, you know, just having a normal life again.
Right now, we're headed up to take care of a lady. They said she's pretty big and that we're gonna have our hands full. At a bare minimum, you'll find that they have some type of decubitus ulcer in between the rolls on their stomach or on their arms. They have different funguses, bacterial infections, which generally can be kind of smelly. Hey there, how you doing, Angela? You're supposed to be giving us a ride somewhere? They got that mixed up somehow. Anybody in the ambulance, they're already having a bad day, so you gotta do your best to cheer them up, make them smile.
I had, like, EDT, and then I had 2 pulmonary embolisms. After that happened, I thought I had diabetes.
EDT and pulmonary embolism.
But I have
She have risk factors for that?
Need a little higher level care, so I'm gonna go and I'm gonna talk to our dispatch, okay? I'm gonna have them send some other people over here.
Feels like I'm kind of like in a jail. The last time I was weighed, I was about 550. And when I look in the mirror at myself, I don't like what I see. I really want to get that person back.
We're gonna have to come to the garage, so, let's go ahead and get this couch in the back, and then, we'll have to remove door pins.
Often we find that we need to alter the patient's house so that we can get them in and out of there safely. I've not once walked into a room and been like, oh, hey, look, they're already inside. Now we're rolling over this way, okay? Yeah. You really got it. Awesome. One, two, three. We have our hover mat lets us slide them right over and causes them a little bit of pain, but nothing compared to what they would normally experience. 1, 2, 3. We actually have a strapping system that specifically goes onto their stomach so it doesn't roll off the side of the cot. Okay, here we go.
Now we're in trouble. Your sugar's pretty high.
You will run into the situation where you start taking their vitals and you realize they're really not doing too good. They might be on the verge of a stroke or a heart attack.
We're gonna do is we give some fluid. It's to knock down your blood sugar, okay?
Instead of, taking them to where they need to be, you need to take them to the emergency room because there is something wrong.
It's always something for me, I'm telling you.
About us, they'd be back confined, they would never be able to get out of the house. That's what this bariatric rig is all about, taking care of these patients and getting them the medical attention they need.
When I first started in my mind, I'd say, man, how do you let yourself get that way? You're just lazy or something like that. But you realize they started this way not by choice, and they definitely don't want to be this way.
Oh, you're bad.
All right, Angela. Thank you.
Any questions?
We don't have any of those types of ambulances in this area, do we?
We do.
Oh,
This doesn't have the winch. It's got the gurney and the supplies set up.
oh, okay.
Matter of fact, they've requested it all over the North State, as far away as Napa, the North Coast, Medford, yes.
What do they know to send them?
Usually a crew's gonna get there and throw, hopefully dispatch figures it out, that's pretty rare. But once crew gets on scene, they realize they don't have the equipment to do it, then they request a bariatric ambulance, and yeah, it takes time. There's no rapid transport with this. Any other questions? Hold on one sec. That's Sam. Yes.
Shouldn't there have been more than 2 people to load them onto the ambulance?
No, so they got the equipment to do it, they got the winch and the ramps,
Okay.
so they don't need more than that. Now, to get them onto the gurney, you can notice they use fire. You get the patient onto the gurney, or they also use, it's called a hover mat. Which is it's like an air mattress, they roll underneath them, then they turn on an air compressor and floats them up and over. Like a magic carpet.
That's fun.
Very, very expensive to run a bariatric units. Any questions? All right, technology assisted devices. First one to go over again, I know we've already gone over it. Hit it again, is tracheostomy tubes. These are now common to see at home.
When a tracheostomy tube is introduced, the functions of the airway can be dramatically changed. Some tracheostomy tubes have a cuff to assure that all air moves in and out through the tracheostomy tube during mechanical ventilation. Proper cuff inflation should be maintained at all times. Overinflation of the cuff can cause many complications, including necrosis and trauma to the delicate tracheal tissues, as well as esophageal impingement with possible swallowing difficulty and reflux. Proper cuff inflation is best achieved by measuring the pressure in the cuff with a manometer. Even with proper cuff inflation, complications arise when airflow bypasses the upper airway, mouth, and nose. Normal sensation and airway pressures are lost. As a result, tracheostomized patients have diminished or absent functions of the aerodigestive tract. Absence of airflow through the vocal folds leaves patients without the ability to speak, causing significant frustration, anxiety, and distress. For children, losing the ability to use their voice during the critical early years of development can lead to significant speech and language delays. Patients with tracheostomies also have reduced senses of smell and taste, which can lead to poor appetite and compromise nutritional status, sometimes requiring supplemental feeding through a nasogastric or PEG tube. In addition, many of these patients have difficulty swallowing and aspirate. The cuffed tracheostomy tube may anchor the larynx, interfering with laryngeal elevation, epiglottis inversion, and airway protection. Because air escapes through the tracheostomy tube when the vocal folds close, positive subglottic pressures cannot be generated during swallowing. Reduced sensation in the larynx and pharynx leads to pooling of material in the airway, and also reduces the protective cough reflex, which is necessary to clear the larynx and trachea when penetration and aspiration occur. When patients are unable to breathe through their nose, they are unable to filter, warm, and humidify the air. This has an impact on the quantity and quality of their secretions. Because patients cannot sense these secretions and generate the necessary pressures to cough, secretions accumulate in the airways, requiring suctioning by a caregiver and increased risk of trauma and infections. An open tracheostomy tube does not allow a patient to generate positive end expiratory pressure or physiologic PEEP. Without PEEP, the alveoli, which are the sacs of air in the lungs through which gases are exchanged, can collapse, causing atelectasis. Significant atelectasis results in decreased ventilation and oxygenation.
Any questions? No questions? This is the most questions we've had all semester. You guys actually had 3 on the last slide. I was like, what? What is this?
Most people know.
All right, so chemical ventilators are home. This is one of the Carrie Hutchins. She was one of the first YouTubers. That was full-time dented. She was waiting for a lung transplant for cystic fibrosis. Unfortunately, she didn't make it. But it's a good video on how that works and what life is like being on a ventilator full-time.
Well, my name is Carrie Hutchins, and I was born in Grand Rapids. I grew up in Sparta. With my family, I was diagnosed with cystic fibrosis. Basically, when I was a little tiny baby, and I was sick more when I was younger, and then more and more as I got older, being in the hospital and for lung and different things, and but generally lived kind of a somewhat normal life, and my family was supportive and doing all my doctor appointments and everything else. But as the cystic fibrosis does to everybody, I know very sick after having my 2 children, which when I was young and parents had me, I'm sure they never guessed I would even have children, that I would even live to be old enough to have children, but I have two wonderful boys. One is 4 years old and one is 13 years old. And that inspired me as I struggle against this disease and to the point of needing organ transplant for my lungs, so needing 2 new lungs. And so I've got to that point of knowing that without that, then I probably wouldn't see them grow up, especially my younger one. After I had him and was thinking about organ transplant, I thought, I looked in that little face and I thought, how could I not do all I can to live to see him grow up? And the only real way for me to do that is through the miracle of organ. And so that's where I am today, and I'm waiting in a hospital now. I waited for 2 years and like 9 months, but who's counting? I probably can tell you the number of days and stuff like that sometimes, but not today. But I've waited in hospital for exactly 70 days because I've gotten too sick to be at home and I to be on a ventilator 24 hours a day, so I can't breathe on it. So I have to be here until I would like say to those of you that gift of life, that are working hard, that slides and work is to give people more days of their life and to give them life beyond what my body as it would be able to have. And I can't say enough really about how humbled I am that other people who've never known me don't have any, really way of, being involved in my life other than, just that you have passion for
Any questions?
organ donation.
All right, apnea monitors. We talked about RUIs, ALTs, and one of the ways to monitor these patients is apnea monitors. Sometimes it's a band across their chest while they sleep. If the band doesn't move, make contacts. This one's actually an airflow, or if it doesn't make the contact after a short period of time, sets off a massive alarm. Parents can't possibly sleep first. I know the baby stop breathing. Pretty cool. Every time the baby breathes, it goes to stick. Good contact stops the alarm going off. Contact doesn't have like 13 to 20 seconds, so it sets an alarm off. That's what an apnea monitor is. Any questions on apnea monitors? I know we already went over this, but we're gonna go over it again. Pacemakers with ICDs, which is implantable cardiac defibrillators. These are ones that shock directly on the heart, so they're only 2 to 4 joules as opposed to 200 joules on the AEDs that you guys use. Because it's directly touching to the tissue, it doesn't have to go through anything. Anyway, here's a good video on it, see if you guys have any questions.
Implantable pacemakers and defibrillators are devices that apply electric shocks to maintain the rhythm of the heart and, if necessary, restart it. As the technology improves and the list of treatable conditions grows, the number of devices being implanted is increasing steadily and now exceeds 500,000 a year. The heart is made up of 4 chambers, 2 atria and 2 ventricles. On each side, the atrium is connected to the ventricle by a one-way valve. Blood is pumped as these chambers contract and relax in turn. The beating of a healthy heart is regulated by electrical impulses. The sequence begins as the atria fill with deoxygenated blood from the body on the right and oxygenated blood from the lungs on the left. An electrical signal from the sinoatrial node then causes the atria to contract, forcing blood into the ventricles. The electrical signal is then picked up by the atrioventricular node and directed into the Purkinje fibers in the ventricle walls, causing the ventricles to contract. And the blood is then pumped through the pulmonary valve on the right to the lungs and the aortic valve on the left to the rest of the body. These valves close and the cycle then restarts. When the sinoatrial node fails to function correctly, an artificial pacemaker can be fitted to help regulate the heartbeat with small, evenly timed electric shocks. This involves implanting electrodes into one or more of the heart's chambers by inserting leads into a vein near the collarbone and implanting a device called the generator just under the skin. For more severe heart conditions, an implantable defibrillator, or ICD, can be used, which is also capable of sensing a stopped heart and delivering an electric shock powerful enough to restart it. For some conditions, an even more sophisticated device, called a CRT-ICD, can be implanted. This uses a third lead inserted into the left ventricle to resynchronize the ventricles when necessary. However, all these leads can cause problems of their own. Patients with ICDs have a 20% chance of a lead failure within 10 years, and replacing leads can require open heart surgery in about 2% of cases. This has resulted in several efforts to develop new pacemakers that do not depend on leads inside the heart. One design, the subcutaneous ICD, places the lead just outside the heart under the patient's skin. And wireless designs are now being developed that may eventually do away with the need for leads altogether.
Any questions? It'd be good thinking of your brother, so when the leads come off, the patient dies. Which is very bad. Any questions? All right, so. I know I've asked you guys a lot. This is the honest truth. These things do exist. They've existed for over 10 years. So. I first started track, what's that?
I've seen one and had to deal with it.
Yeah. When I first started with these first guys, started training people, and they didn't believe me. So left ventricular assist device. These are for people that have had major heart attacks or in severe cardiogenic shock. That's again. So it was initially developed as a bridge to transplant, to keep someone alive until there's a heart available for transplant. Then they started using it for after major heart attacks, hoping the heart would also heal and get a little bit better. And now they're using it just to try to keep people alive with a better quality of life. So what it is it's not a heart transplant. It's not a mechanical heart. It's a left ventricular assist device. It's called LVAD. So they do is, I got videos to show you how to do it. They bore into the left ventricle and put a hose in. And the hose runs into a centrifugal pump. And then the centrifugal pump boosts the flow and puts it back into the aorta and goes out the rest of the body. Which is great, except for one problem, well, a couple of major problems with that. It's a constant flow. It's not the usual, as the aortic valve goes open, you get a flush of blood. That's a wave throughout the entire body. That flush of blood, what do we call that? It comes out of the left ventricle. It goes through the entire, all the arteries in the body. We call that a pulse. Yeah, systolic pressure, but it's a pulse. That's how we feel the pulse, is that wave of blood when the left ventricle ejects. So when you have a constant blood flow coming through a rotary engine that's running constantly, how do you check for a pulse? You don't, there is no pulse. And if you can't check for a pulse, how do you take a blood pressure? Because how do you take what's the whole way that you do a blood pressure? You pump up pressure against the artery wall until you can't hear the pulse. And then when you start hearing, you get the systolic. When you stop hearing, you get the diastolic. So if there is no pulse, that's a constant flow, how do you get a blood pressure? You don't. How about pulse oximetry? Pulse oximetry is a red, white, and a white light that transits through the skin that measures the pulse wave going through the skin and how much of the oxyhemoglobin reflects back to the sensor. So there's no pulse oximetry. So if they're unresponsive and not breathing but still alive, how do you know? Anybody want to take a guess?
And you can take a map on those patients who just can't get like, just a normal blood pressure like you would take on me.
It's highly inaccurate. Sometimes you can't get them at all. I've taken these people all the way to Sacramento and never got blood pressure. Just depends.
Cause I've taken maps quite a few times on.
If their left ventricle is strong enough to produce enough of a pulse for you to do that. But if it's not, and the rotary engine is overpowering it. Or you gotta find somewhere like close that's like maybe the femoral, where you take a femoral or you take an arm.
I do it from the AC typically with the Doppler.
Oh, you have Doppler.
Yeah,
Yeah, I guess you could do that. But generally, you're not gonna have that in EMS. So capnography is the only way to do it, measuring exhaled CO2. They can exhale CO2, they're still alive. Dead people don't exhale CO2. So they're not generating it cellularly. Make sense?
so that's that little thing that on the BBM, yeah, okay.
What we use on the IGL.
Okay.
This one's a first generation and gotten a lot better than this.
The heart has 4 muscular pumping chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. The left ventricle pumps blood out through a large artery called the aorta to supply the body with the oxygen and nutrients it needs. In left-sided heart failure, the left ventricle is not able to pump enough blood to the body. The 2 types of left-handed heart failure are diastolic, where the left ventricle can't relax enough to fill with blood, and more commonly, systolic, where the left ventricle can't contract strongly enough to push blood to the body. In severe or end-stage heart failure, the heart is getting weaker and doesn't respond to medication. For left-sided end-stage systolic heart failure, a doctor may recommend an implantable left ventricular assist device, or LVAD, to help the heart pump enough blood to the body. An LVAD is a small mechanical pump implanted inside the chest or abdomen that takes over the job of the weak left ventricle. Blood flows from the left ventricle through an inflow tube to the pump. The pump pushes the blood through an outflow tube into the aorta. From here, the blood travels normally from the aorta to the rest of the body. A cable, called a driveline, connects the LVAD pump inside the chest to a control unit located on the outside of the body. The control unit is a small computer that controls the functions of the pump and alerts the patient if there are any problems. The pump and control unit receive power through a cord connected to a battery pack. Finally, the control unit and battery pack are held in a lightweight patient pack. An LVAD may be a temporary treatment until a heart transplant can be performed. Or, if the patient isn't able to have a heart transplant, an LVAD may be used for destination therapy, which is long-term treatment.
Any questions? Believe it or not, that's been out for over 10 years now. Time goes by. Now they got new modern ones where it just, the pump goes right into the cornea of the heart. It's just pretty amazing.
I got a question.
Yeah.
So if you do get a heart transplant, you said that you have to be on medication the rest of your life. If it,
You have to be on anti-rejection meds, yeah.
and there's no way impossible it could stop using that medication, like your body won't adapt to it on its own.
Yeah. Unless you Which they're getting really close, they could 3D print your own cells into a heart, then you want the anti-rejection medications that be your own DNA.
What if it's like your brother or sister?
No.
Same thing?
Still not even close now. Yeah,
So you said like, you would only know if they're like dead, basically, if there's no carbon monoxide coming out, or
carbon dioxide, but that's only if they're not breathing and they're unresponsive.
how would you bring it back, like, let's say you saw that they were like breathing. And.
They're breathing, then you know they're alive.
But then like they stop with you.
You start ventilating them and you put a capnography on them.
Okay.
And that'll see it too. Any questions?
And then what? Would you do CPR on that?
Yeah. Well, that's gonna be up to your local protocol. So initially they said, no, don't do CPR. Because it'll dislodge the catheter from the ventricle, and then of course they'll bleed out to their chest. Then they started thinking about it, said, well, if their heart's not beating, it doesn't matter, the LVAD can't do it, so you got nothing to lose, so why not do CPR? So now you do CPR, but I don't believe there's been a documented case of someone surviving.
Okay.
Yes.
Did you say you could reprint your own cells from it?
Said they're working on it. Yes, they are working on making your own body parts from your own cells and 3D printing.
That's great.
But all anti-rejection drugs are is immunosuppressors. It just suppresses your immune system so it doesn't reject it because it's a foreign DNA inside your body, so it's naturally your immune system's gonna attack it and kill it. So all anti-rejection drugs are is immunosuppressants, which is why those people can't be, if someone that's transplant person can't be around anyone that's been sick or is sick. It'll kill them. Any questions? All right, let's go over central venous catheters. I know you guys went over this in pediatrics, so we're gonna go over it again. People that are having long-term treatments and stuff. We'll have. Just gotta go through how they put it in. Hey, this is gonna be an internal. We gotta go and line my landmarks. This was the needle and plug in the retrograde. Old blood test, and we got to put a guide wire down the vein. You got guide wire, put it down, guide wire. Guide wire. It's quite a process. No rip these out.
Ideal candidate with input is present on the
No, it's a good one, actually starting to work for the. This noise, I played it some last.
practice it.
Any problem with that? Explain practice. The confident content of the company.
क्या सर हेडलाइन एक्सेप्ट नहीं नसीम से बोलते थे करने के लिए लेकिन इसमें इंटीग्रेशन में डर नहीं लगता है, इस पे पता नहीं क्यों अजीब लगता है।
Yeah. Who's going blind. So there's no problem, they can draw that blood out of those from a jugular. This not.
Maybe then consumption is 9 months. So that's it.
Right, two.
कौन सा पेशेंट है वहाँ पे देखो कौन सा पेशेंट है
There you go. Any. Now I got to run a guy player in. With Catherine, guide wires, that's how they have such light.
ट्रीटमेंट बहुत बढ़िया रहा क्योंकि अगर पेशेंट का फ्लेक्सर रिस्पॉन्स आ रहा है शोज रिस्पॉन्स अच्छा रहना रहता है और न्यूरोलॉजिकल पॉइंट ऑफ व्यू तो आप लोगों ने समय रहते हुए तब काम किया बेसिकली अगर किसी ने करने की तरह किया तो और फिगर जो होगा उधर से मॉनिटरिंग होती है तो एयरवे की जरूरत नहीं होती सिर्फ क्रॉस कटिंग टेक्निक से ज्यादा
You guys ever understand everything she's explaining to you about this? Yeah. Alright, G tubes. These are people that can't eat through their mouth and esophagus, they gotta be fed through a container.
Your doctor may perform a percutaneous endoscopic gastrostomy, or PEG, to insert a feeding tube into your stomach if you are unable to take food by mouth for an extended period of time. Digestion of food begins in the mouth. When you swallow, food is pushed down into your esophagus, a muscular tube that carries food to your stomach where it is digested. From the stomach, food travels to your small intestine, where digestion continues and nutrients are absorbed into the bloodstream. Your doctor may require a PEG feeding tube if you cannot eat, digest, or absorb food due to esophageal cancer, oral surgery, or stroke, major surgery, trauma, burns, or anorexia, inflammation of the pancreas, or radiation therapy, or inflammatory bowel disease affecting the small intestine. Before the procedure, you'll receive a sedative through an IV to help you relax. A local anesthetic will be administered at the site on your abdomen where the PEG tube is to be placed. The most commonly used PEG placement procedure is the pull method. During this procedure, your doctor will insert a lighted endoscope through your mouth and thread it down your esophagus and into your stomach. A camera attached to the endoscope will produce images of the inside of your stomach, which will be displayed on a video monitor. Next, your doctor will insert a needle through your skin into your stomach at the location where the PEG tube is to be placed. While doing this, he or she will use the endoscope to locate the end of the needle inside your stomach and encircle it with a wire snare. Your doctor will then pass a thin wire through this needle into your stomach, attach the endoscope to the wire, and pull both the endoscope and wire out through your mouth. At this point, there will be a thin wire entering the front of your abdomen into your stomach and continuing upward and out of your mouth. Your doctor will attach the PEG feeding tube to the wire outside of your mouth. By gently tugging on the other end of the wire, he or she will pull the tube back through your mouth and esophagus and into your stomach. Your doctor will continue to pull until the tip of the tube comes out of the incisions in your stomach and abdomen. A soft round bumper attached to the portion of the tube that remains inside the stomach secures it in place. The outer portion of the tube will be secured with a bumper as well, and sterile gauze will be placed around the incision site. In the alternative push method, your doctor will begin in the same fashion by using an endoscope to guide a wire through your abdominal wall and into your stomach. But instead of pulling the PEG tube through your mouth, he or she will push it directly into your stomach over the wire. After your procedure, you will continue to receive fluids through an IV for 1 to 2 days. Once there is evidence that your digestive tract is functioning, you will receive clear liquids through the PEG tube. If clear liquids are tolerated, you will receive a tube feeding formula through the PEG tube.
Any questions? Any questions? You hanging in there Friday with all the videos? Shunts. So again, this is when people have hydroencephalitis. You put it at the base of the skull, run it down the inside of your neck, down to your peritoneum, and let the cerebral spinal fluid drain into the peritoneum. No narration on this one. But good visuals. Just drill a little hole in your skull, put the catheter in, run it down inside your neck and your chest, down into your peritoneum. Let the cerebral spinal fluid drain. There it goes. Any questions? Works great until it gets plugged or fails. Vagal nerve stimulators, they use these in Parkinson's. What it does is stimulates the parasympathetic response that it actually works to stop the shaking of Parkinson's, which is pretty cool. I don't have the video anymore, wasn't much of a video, I just shows how they wrap it around the stimulate around the vagal nerve. Usually once you have a remote control, they turn it up or turn it down depending on how they need it.
Not help with tremors as well?
Yeah.
Okay.
Absolutely. People with a colostomy and ileostomy. What are we doing, folks? Oh God, that guy again. Everybody's leaving.
You've seen one, you've seen all.
It was a pretty good video though.
I'm Helen and I'm the helpline manager for Ostomy Lifestyle. I'm going to use the anatomical apron to explain how our digestive and urinary systems work
I think she's British.
Maybe a little bit.
and how stoma surgery is performed.
That's an evisceration.
When we eat and drink, the food and drink travels down from our mouths, down the pipe that leads from the back of our mouth, down through our throat, which is our esophagus or our gullet, into this organ here, which is our stomach. Your stomach is about the size of your clenched fist when it's not doing anything, but obviously it expands when we eat to accommodate the food we've eaten. Your stomach's job is to break the food that you've eaten down into a kind of a mush. So the stomach really is just a big acid bath. Once the stomach's done that, it passes that mush into this very long structure in the middle, which is your small intestine. And your small intestine is the really important bit of your digestive system. It's where all the absorption of your vitamins, minerals, and nutrients happens. So it's a really crucial bit. Once your small intestine's done that job, it passes what's left, which is kind of the physical matter of the food you've eaten, plus lots of the fluid that you've drunk, into this structure here, which is your large intestine or your colon. This little bit hanging off the beginning of your large intestine is your appendix, which doesn't really do very much. I think the best way to think of your large intestine is like a tumble dryer. When the food waste enters the large intestine, it's quite full of moisture, and the large intestine's job is to reabsorb that moisture into your bloodstream. So as the poo moves along, it becomes gradually more and more formed. So it travels up, across and down, and into your rectum, which is in your bottom. And this is where you start to get the sensation that you need to go to the toilet. And when you're ready, the poo exits your body via the natural opening in your bottom, which is your anus. So that's how your digestive system should work in an ideal world. If there were to be a problem in part of your colon, for instance, let's take the rectum as an example, a surgeon may need to remove it. So an example of why this might be the case would be something like rectal cancer. So in this scenario, I'm going to show you how the surgeon would open you up so we can see what's what, and cut through the bowel above and below where the problem is. And that affected portion of bowel will be removed. Now this bit here is the end of the system. So everything else in the body is still doing its original job. It's just that the journey ends a little bit sooner than it used to. And for various reasons, this can't be connected to the natural opening in your bottom. So what the doctors do instead is they create a new opening. And they do this by making an incision in your abdominal wall and pulling that piece of colon out through that opening. Like so. And they sew you back up, put everything away again. And this bit of bowel, they turn back on itself and stitch it down to secure it. This is called a stoma or ostomy. They both mean the same thing. And this particular type of ostomy is a colostomy because it's an opening from the colon. Normally, colostomies are on the left-hand side of your body, and you would normally wear a closed bag to collect your waste from your colostomy. If I take another example, let's imagine that the whole of the colon is diseased and needs to be removed. Or perhaps a portion of it has been removed and they want to give the bowel a rest while it heals. In these scenarios, they might perform an ileostomy operation. So the end of your small intestine is referred to as the ileum. So the ileum is where the small and large intestine meet. And to create an ileostomy, they would separate the small and large intestine and bring out the end of the small intestine as a stoma, just like before, except this time, normally, it's on the right-hand side of the body. And normally, you'd wear a drainable bag over that because what's coming out of an ileostomy has a higher water content than what comes out of a colostomy because it hasn't been tumble dried yet. So you'd empty your ileostomy bag a little bit more often. Your urinary system is made up of your kidneys, your ureters, and your bladder. Your kidneys aren't really in this position. Your kidneys in your body are down here in your back, one either side. Your kidneys are really hard-working organs. They're your blood cleaners. All the blood in your body regularly passes through your kidneys and is cleaned. The good blood gets put back into circulation, and then if the kidneys find in the blood that it don't like, they'll put into water to form urine. So your kidney's job is to clean your blood and create your wee. The urine drains away from the kidneys down these two tubes, your ureters, one from each kidney, and carries the urine into your urinary bladder, which is a stretchy sac that can hold about a pint of liquid. When you're ready to go for a wee, the urine exits your body via the natural opening, which is your urethra. If there were a situation that required your bladder to be removed, most commonly something like bladder cancer, the surgeon would separate the bladder from the ureters. And you might think the obvious thing to do would be to bring the ureters out to the surface to drain the urine away. However, they're a bit small and they're not really very good for that job. So what they do instead is they borrow a segment of small intestine, piece of your ileum. They sew it up at one end and this other end is open. So the kidneys continue to produce the urine as before, which drains down along the ureters and into this channel. And that open end is then brought out as a stoma on your abdominal wall. And this is called a urostomy because it's an ostomy opening for urine. Most commonly, it's on the right-hand side of your body, and that's simply because your right-hand ureter is just slightly shorter. If there were a good reason to, you could have your urostomy on the left-hand side. You would wear a bag with a drainable tap at the bottom to drain the urine out of your bag as and when you need to.
Any questions? She actually did a really good job there. So that can make you watch all of these.
Caution, the hardware.
This one is the more modern one, which is pretty cool. For LVAD.
The hardware ventricular assist system is a miniaturized implantable circulatory support system for the treatment of advanced heart failure. At the core of the hardware platform is a proprietary suspension system for the wide-bladed impeller. Using a combination of both hydrodynamic and passive magnetic forces, a thin layer of blood is established between the impeller and the pump housing. During operation, there are no points of mechanical contact within the pump, effectively creating a wireless system. The HVAD pump, roughly the size of a golf ball, is capable of providing up to 10 liters per minute of blood flow. Its small size and integrated inflow cannula allow the device to be implanted completely in the pericardial space, directly adjacent to the heart, thereby avoiding abdominal surgery. The implant procedure makes use of a proprietary sewing ring and custom apical coring tool, which allow the pump to be attached to the apex of the left ventricle. The outflow graft is then attached to the ascending aorta. Once in place, blood flows from the left ventricle through the inflow cannula into the impeller. It then exits through the outflow graft to circulate throughout the body. The driveline cable, constructed with fatigue-resistant conductor wires, similar to those used in pacemakers, exits the patient's skin and connects the implanted pump to an externally worn controller. The controller is powered by 2 lithium-ion batteries, or 1 battery plus an adapter connecting to a wall or vehicle electricity outlet. The controller operates the pump.
Questions? All right, hospice. So hospice is a very, very good thing for our society. So hospice is when you know that you have no chance of surviving. You are terminally ill or injured, and there's no benefit to you, or you don't want to continue and take heroic measures. So instead of calling 911 and being in the ER all the time, being stuck in these and giving medications, what they do is you put yourself in the hospice system where they make you comfortable, they medicate you, and you relax and just hang out until the inevitable happens. Now, some important things you know in EMS is if hospice is being done correctly, which a majority of the time is not being done correctly in 2026, the family of the patient should be educated in how the hospice system works. So if they are on hospice, they should never be dialing 911. They've already made the choice that they do not want heroic measures or any life-saving measures to be taken. They're just being comfortable until the natural process takes its course. They should have a hospice nurse that's on duty 24/7 that they're able to contact if there's complications or problems. And that's who they should be contacting. Unfortunately, post-COVID, we do not have the education, the infrastructure hospice that we used to have. So there's a lot of people falling through the cracks. The education's not there, the family education's not there, and they call 911 a lot. So if you are there, sometimes you don't even know these are hospice patients. There's nothing you can do about that. But if you discover they're a hospice patient while you're on scene, you as the EMT have to educate them that if they go to the ER, they will be taken out of the hospice system. And they will not be allowed to go back into it. Now, they can make that choice, sometimes they do. But the family of the patient have to be completely aware that they're leaving the hospice situation, and they won't be allowed back into it, because it's a whole financial thing on how hospice works. Now, if they decide they don't want to do that, what you have to do is find out which hospice program they're with, and call the 24/7 number to get a hold of their hospice nurse for direction. Now, let's say they're a lung cancer or end-stage CHF or COPD patient, they've fallen and broken their hip. The hospice nurse may approve for them to be transferred to the hospital to be looked at. It is possible. Or they may come up, just let them look more morphine or Oxycontin. Who knows what they want to do? You have to let the hospice program make that decision. Does that make sense? And if things were done correctly, you shouldn't be there in the first place. Unfortunately, more and more, you're going to be drawn into those situations. Any questions about hospice? How hospice works and what to do if you are mistakenly called to the scene? No questions, all righty. Poverty and homeless are huge, huge burdens on the EMS system. Unfortunately, people use the EMS system because there are laws, especially in California, that if you call 911, you cannot be denied service. So if you are cold and wet or starving, you can call 911, get to an ER, you will be fed, housed, and get dry clothing. And they'll even pack you a lunch to leave and stay long if you have to.
How long do you stay there?
Until they kick you out. They might kick you out in under an hour, but they'll give you dry clothing and a lunch. So that has created 911 calls for very big complaints multiple times a day. City of San Francisco had one guy that called 911 26 times in a 24-hour period. They kept taking him to Mission Emergency, which is the level 1 trauma center. So they put him in what's called the Gurney Garage. It's a perpetual state of triage. So they're going to get to you, but you have to wait for the more critical patients. So he just get up and walk out, walk down the street, pick up a phone booth, call 911 again. They go get him, they legally have transport and take him back to Mission Emergency, put him in triage, get out of triage, walk down the street, call 911 again. So you kept an entire ambulance crew out of service for 4 hours.
Should have just, they should have just admitted him at that point for the night.
But how do you? There's no beds.
No, that's
I mean,
true.
You got 200 people inside your ER. What do
Somebody
you
get
do?
that man a hotel. Just get him a room.
It's not uncommon right now in the cities of Sacramento and San Francisco to have 85 admits holding in the ER waiting for beds. It's that bad. Any questions?
Worse than what it is in summer.
I don't know. I never thought about it. Never studied it. Couldn't tell you. My gut would tell me it's worse in the winter, but we get this, but then the summer brings a higher population of transients, so people come here to live on the mountains. And sometimes find out living on the mountain's not that great. Bugs, snakes, bears. Any questions? All right. Let's see what you guys have learned. You're dispatched to a man with general weakness. What do we do first? Find out if he's really a general, or is he a lieutenant or a captain. All right, you have your VSI on, you're at a single family dwelling, it appears to be very safe. Patient states he's too weak to walk. You've got good resources and you see absolutely no indications for spinal precautions. What's next?
Primary assessment.
Primary assessment, UTEX got it nailed. General impression is a guy in his mid-70s. He's alert. He's too weak to walk, his airway's patent, breathing adequately. You're unable to palpate a radial or a carotid pulse, but he's alert. He's ashy, warm, and moist. This is a priority patient, you don't have a pulse. Should you start CPR? Oh, yes. He's alert. Should not start CPR. What's next? You're the only one that's gonna answer the questions today. Everybody else can go home. Just kidding, you're not leaving. Sample history, began this afternoon after eating, severe weakness, the radiation is not applicable. It's severe, it's been going for 3 hours steady. No drug allergies, got a whole shoebox full of medications. Past medical history of severe heart failure and renal failure. Lunch was the last meal, and he's been unable to walk since having lunch. What's next? Anyone but you, Ted? Oh, look at that, you guys can't see. I'm so proud. Vital signs, you're unable to get a BP or a palpable pulse. Respirations are 16. GCS 15. Chest, he's wearing a large vest with batteries, tubes, and wires that enter next chest to a couple of different places. Can't hear lung sounds due to a machine in the vest to help to sound like a rotary engine. Abdomen soft, not tender, his pelvis stable. Extremities are unremarkable. Can't get an SpO2 either. What's going on?
Oh.
Exactly. All right, any questions? You should have a companion with them. If there's an LVAD, bring the companion with you. They know how to change the batteries, the pumps, all that stuff. You don't. Caldwell, question.
I got it answered already, I just have to think about it.
What is that?
Oh, I was like, it's a dumb question, never mind.
Oh, maybe somebody else had it. Could help them out, but that's okay. Any questions? All right. If you guys go to break, study back by 8 o'clock.
Oh, yeah, no problem.
Are we meeting?
Take a breath, fresh air out.
Are we coming back in here or in the other room?
Oh, we'll go back in the other room.
Are we coming back here?
Still wearing a Dodgers hat. Be determined.
Well, I didn't even see it, can we?
Yeah.